Good afternoon, everyone. I'm going to do a little case presentation here. I have changed the name to protect the innocent. We'll be referring to the client as Peter Parker. Hopefully, you all know who that is. Anyway, so this is the case of Peter Parker, and we'll start off with some demographics. Peter is a 16-year-old biracial boy. He's recently been released from a 2-year residential placement for child psychiatric patients, and he is currently diagnosed with ADHD, combined type, oppositional defiant disorder, post-traumatic stress disorder, and he also has fetal alcohol syndrome, and he meets the criteria for mild intellectual developmental disorder. So he has a lot of things, both physical and mental, that he's dealing with. In spite of all this, Peter is very resilient and tenacious youth. He struggles academically, socially, and cognitively, although he is quite comedic and seems to have a pretty upbeat attitude given all the trauma that he's been through and his current circumstances. He does need help identifying alternative coping skills to utilize when he's angry and upset. He also really needs assistance in managing his moods and emotions, and really managing his emotional regulation, especially when he doesn't get what he wants or get his way, or he perceives that he's been wrong, which happens quite often. And I suspect that that is a part of his cognitive impairment, where he gets these singular ideas in his head, and there's really no convincing him otherwise. Some barriers to treatment and goals. Peter's cognitive impairment, as I mentioned before, he's also got an intellectual disability, brain damage from exposure to alcohol and euro. These all act as major barriers to engagement in therapy and really hinder his goal attainment. Even just identifying goals are quite difficult for Peter. He does need a lot of support and a lot of help in that area. Additionally, his past trauma and the length of time that he's been in and out of placement, which has been 10 of his 16 years, this has really led to a great deal of mistrust in the system, and especially, as he calls it, so sorry, new staff. And he's had a lot of, he's really spent so much time in placement that it does seem like that has kind of become his normal. So home life is a difficult transition for him, or even a difficult concept to understand, at least permanent. Okay, so presenting problems. Um, just to kind of backtrack, he was originally sent to a psychiatric hospital, and he had an evaluation, and then because of his suicidal and homicidal threats, he ended up having court involvement and then being placed in a secure detention center for 2 years. So quite a long time. Currently, he's really non-compliant, both verbally and physically abusive towards his peers, his siblings, and anyone that tells him no, or tries to hold him accountable for his actions. This makes it difficult at school and also at home, because his parents have to be structured just because of the fact that they have so many children in the home, and it's classified as a therapeutic foster home. And there are 12 or more children. So Peter also, he was another piece to him being placed was that he made homicidal threats towards the teacher that while at school, but also um, suicidal threats towards himself for self-harm. He also has a history of absconding and involvement with local law enforcement as well as family court, and he recently ran away for 2 days. He was picked up by the state troopers, 941 to the psychiatric unit of the ER, and now he's in a temporary crisis respite, which is another program that's a part of our agency. So because of that, he's picked up he's got three pending JD charges, one for assault, one for robbery, and another one for destruction of property. Um, he presents, where he originally presented as being agitated, angry, and not interested in engaging in therapy at all. So some biological factors or biopsychosocial factors and environmental factors contributing to these problems. As I stated before, he has mental health diagnoses, ADHD, ODD, PTSD, um, mild intellectual disability, um, as well as physical impairment and possible autism spectrum disorder, which if I was able to spend a little bit more time with him, I could get a definite answer on that. Um, he did he does have some brain damage from exposure to alcohol in utero, and additionally, his past trauma and the length of time that he's been in and out of placement has led to a great deal of mistrust for new providers or people in general, as well as living in a therapeutic foster home with 12 other siblings, all of whom have some form of mental health or physical disability, and this all contributes to the maladaptive behaviors and behavioral problems that Peter's experiencing. Current progress, um, measurements of achievement. Peter's maladaptive behaviors have worsened since he enrolled in our program 3 months ago. This is right after he got out of placement and returning home after 2 years away. He's um, he's returned to a lot of his old behavioral patterns of dysfunction in the home, the school, and the community. He's recently been suspended. Like I said, he ran away, and now he's currently in a temporary 21-day crisis respite that's run by one of our other programs from within the agency. However, after 2 weeks of being in the crisis residence, he's made a huge turnaround, and his moods and emotions are much more stable. This might be because he's one of only 3 residents, um, and there are a large number of staff, usually 3 or 4, up to 5, on site at all times, and he's getting much more one-on-one attention than he normally does at home with the 12 siblings. I'll touch a little bit more on that later. The role of the social worker at my agency, I act as one of 3 clinicians on a team. We all meet with Peter individually for therapy and also conduct family therapy and group sessions with the youth and his peers that are in the same program. Given Peter's cognitive level, the social workers also can act as mentors and case managers when needed. Um, we also conduct preliminary and comprehensive assessments, safety assessments, and we also assess for suicidality using the Columbia risk assessment and the Stanley Brown safety plan. There's some internal resources available through our program. He has access to a 24/7 crisis line that is answered by one of the 3 clinicians or the program manager. Additionally, the team offers a mentor, a peer advocate, and we have an on-site psychiatrist that offers medication management as well as psychiatric services and even transportation. While he's in school, he has access to the school nurse and the school social worker. Honestly, excuse me, my biggest concern with Peter is that when he gets escalated, he becomes really violent. He's difficult to reason with. He also gets, like I said, very um, singular in his thoughts, and he gets fixated on being right or just one idea. He doesn't want to veer away from that, and he doesn't feel that he needs to listen to what anyone has to say. He he very rarely takes ownership for his actions, and he's continually blaming his circumstances or the actions of others for all his maladaptive and destructive behaviors. Um, these factors are creating major barriers to client engagement and his willingness to change. And it's really hard to, I don't think he can cognitively do it, but it's difficult to get him to consider alternative views or possibilities as to why he's in the legal trouble that he is, or why he's being suspended, or um, experiencing all these dysfunctions. As I kind of mentioned before, since he's been in the crisis respite, he's actually made a big turnaround. It's my recommendation that Peter begin to process being reinstated back into society or back into home life. Um, and it's quite challenging because he's really been there for so long that he's essentially institutionalized, and it's hard to break that pattern. Um, I would also suggest a home environment that affords him the love and affection that he's not currently getting in such a large household amid the 12 other high needs children who also only have two parents total for all of them. Additionally, I would implement more activities into his life that promote trust and start teaching Peter to become more independent as he moves closer to adulthood. He'd still have to be in a very supportive and highly structured environment, but I think if he could start working on some social skills, possibly some employment skills, he would have a better shot for his future. And then finally, observing Peter in his new environment at the crisis residence, where he has more autonomy, freedom, and one-on-one attention from adults. And given that he's shown improvements in all domains, this suggests that Peter's dysfunctions could be lessened in a different home environment that's more nurturing, predictable, and less chaotic. Seeing Peter's situation in light of person and environment suggests that many of the psychological issues that Peter is having might be more environmentally informed than biologically, as was my previous assumption. It also really begs a question: if Peter and others like him had not experienced so many adverse childhood experiences, especially the abuse, neglect, abandonment, and maltreatment, and they started their lives out in a less dire home environment, what might they be like today as young adults? Um, Childhood trauma seems to be the biggest influencer or cause for adolescent and adult dysfunction. And I hope you enjoyed the presentation. Good luck with the rest of the class.